Good job finishing chapter 12. That was a very heavy chapter, so make sure that you take the time and really study that one. That's the foundation for a lot of what we do in neurology. This chapter, a couple of chapters, I'm just highlighting a little bit out of 13, 14, and a little bit of 21. We'll revisit 21 a couple more times in order to really understand the visual system and the vestibular system and how those two things go together. So this one's just kind of like a highlight of these two chapters. So when you are triaging your time and you're reading your book, please read in its entirety chapter 12. You can skim through chapters 13 and 14 in order to gain a little bit more insight into these couple of cranial nerves that we'll dive into. And then we'll get into chapter 21 again a little bit later. So feel free to just skim 13, 14, listen to this PowerPoint, take your quiz, and move on to the next chapter is the design of this class in regards to that. So let's go ahead and dive right on in. We're going to talk about chemical senses of taste and smell, hearing and balance, and a little bit more about that 8th cranial nerve than we did last chapter, and then bring it together with eye movements. Chemoreceptors respond to chemicals in an aqueous solution. So what does this mean? This means that we salivate, right? Like our buddy the dog there looking at the grill. And then what is that dog doing standing like that? I like that picture. So the other picture there is reminding us of the salivatory nuclei. If you look over to the right in that picture in purple, all the way to the far right, we can see the superior salivatory nucleus and the inferior salivatory nucleus. Remember, superior 7, S for S, superior 7, and then inferior salivatory saliva nucleus is 9. So chemical senses of taste and smell. So we're talking about taste buds, and we're going to call them gustatory receptor cells because, of course, we can't just simply call them taste buds, right? And then we're going to call olfactory receptor neurons. That's mediating the sense of smell. We need to be able to smell in order to taste appropriately. And then we have something called the common chemical sense. Chemosensitive endings, such as some trigeminal endings in the mucous membranes that mediate common chemical sense. So this is where you're going to get heat from the chili peppers, the sting from ammonia, coolness from menthol, not necessarily a taste, but it's a sensation, and that's going to be trigeminal. So remember, bitter is 9, bitterback 9, 7 is sweet, but it's also salty, sour, and pretty much the whole anterior 2/3 of the tongue, and anything that isn't bitter, because bitter is 9, and then any other sensation, including pain, is going to be trigeminal. You'll also get some taste, a little bit of taste sensation in the back of the throat, in the back of the mouth area from 10 as well. Perception of flavor involves gustatory, olfactory, trigeminal, and other inputs. So flavor is a combination of direct chemical stimulation of the taste buds, olfactory vapors from food, stimulation of the chemical sensitive and somatosensory free nerve endings of trigeminal and other nerves in the mucous membranes and oral nasal cavities. So here's a picture of the root of inhaled air, and imagine that that's something good smelling in there, maybe some good food. And then it is hitting the cranial nerve 1 there. You can see that's the one that I say it looks kind of like a hairbrush, right? So that is the olfactory nerve, and we can see the olfactory bulb and the olfactory epithelium and the nasal concha. Those kind of they're kind of like turbines that warm and slow down and moisturize the air as it comes in. The picture on the right is your Nolte book, and you have access to that in maybe you have the book online. Taste is mediated by receptors in the taste buds, remember, by 7, 9, and 10. And so I put in the picture here of not just the tongue on the left, but the tongue on the right, and specifically what cranial nerves are innervating what. Remember, it's bilateral. It's not one side is this taste and one side is the other taste. That would be kind of a weird sensation, I would think, wouldn't you? Here is a close-up of that back V-shaped, the valley or valate papillae, innervated by cranial nerve 9. It's that back V shape in the back of the tongue. Here's a structure of a taste bud. So the pictures there are on the right. Above obviously is a drawing, and below is an enlarged view of the taste bud under a microscope. So there's about 50 to 100 flask-shaped epithelial cells, two types. Okay? So gustatory epithelial cells are our taste cells, and we're going to have microvilli or gustatory hairs are the receptors. We have three types of the gustatory epithelials. Okay? So one releases serotonin, another lacks synaptic vesicles, and then another one releases ATP as a neurotransmitter. So I find that kind of interesting. So serotonin specifically always catches my eye because we have so many people dealing with depression, anxiety, and chronic pain. And look at that. So eating, we know that. Eating makes us happy. So it's kind of that pre-programmed response there of we're going to get serotonin release specifically if our taste buds are happy, right? Basal epithelial cells are the other type here. So we have gustatory and basal. And then the basal epithelial cells are dynamic stem cells that divide every 7 to 10 days. So you bite your tongue or you have some sort of damage, we're going to get that repaired pretty darn quick, right? So thank goodness it repairs quicker an injury of the tongue than the rest of our body, right? Another little bit bigger of a picture for you here so you could take a look. Make sure you stop and pause and look at any of these structure pictures. Remind you of the 5 basic taste sensations: sweet, sour, salty, bitter, and umami. So number 1, sweet. Obviously it's going to be sugar and saccharin, but alcohol is a sweet taste as well. So when we're dealing with fake sugars, keto diet uses sugar alcohols. So that's the thing that you want to kind of be aware of. Some of them can lead to gastric upset and distress. Other ones like erythritol are usually a little bit safer, but things like sorbitol, anything with that OL at the end of it, you want to kind of assume that that's going to be a sugar alcohol, and it doesn't count against their total carbs or total sugars for the day if you're looking into the keto diet. Some amino acids are going to be sweet, so specifically fake sugars like aspartame are going to be kind of broken up chains of phenylalanine, so you want to watch out for that stuff. That stuff's poison. That's not a good idea to be taking. Some lead salts, again, don't eat that. Okay. Sour, hydrogen ions in solution, and I put a little Sour Patch Kid over there as an example, kind of sweet and sour. Salty, metal ions, inorganic salt, so sodium chloride tastes the saltiest, so salt is salty, right? But we have other types of salts as well. Bitter alkaloids such as quinine and nicotine is bitter, caffeine is bitter. Non-alkaloids are things like aspirin is a bitter taste as well. Umami. So umami, you want to think of that with MSG or monosodium glutamate. So we don't want monosodium glutamate in our diet, but there are natural small amounts of it that occur naturally in some foods. So this is going to be like that mushroom sauce taste that you get at some restaurants, or beef or cheese taste. So that really kind of earthy, grounding taste that some people crave. We don't get that much of it, so when we do get MSG put into our food, it really excites these taste buds. So not a good idea to add MSG to foods, and kind of watch out for all of the hidden sources of that. A lot of times that can cause migraines and nerve issues, and can act as a neurotransmitter in some cases. And the reference over there is the Umami Burger. Okay, so Umami Burger, it's a chain. It's in Chicago and some of the other major cities, and it's touting that kind of savory taste as well. Basic taste sensations here, another add-on, maybe a possible 6th taste, growing evidence that humans can taste long-chain fatty acids from lipids. So maybe this is why we like fatty foods. Okay, so why do we like butter so much? If you actually just taste butter, it's gross. Don't taste it. I mean, I guess you could. But, you know, have you ever tried to just like eat a little bit of butter? It's not actually tasty. It's only tasty when something is, when it's on something. So again, it kind of fits in with that. It has to be dissolved in an aqueous, or in this case, a lipid solution in order for taste to be distributed along our tongue. So our taste, dislikes, and likes have homeostatic value, hopefully. Okay, that's the way that we're designed. So we seek out fruits and vegetables if we're lacking certain nutrients. Things like chocolate, we seek out chocolate because some thought processes here, which I personally believe this is true, that we're magnesium deficient, and that's why we're seeking out chocolate. Amongst other things that make us feel good from the chocolate, it helps to stimulate serotonin release, things like that. But it's a guide intake to beneficial and potentially harmful substances. So we don't really go, oh, wow, I'm craving Easter Peeps, right? So that must be of nutritive value to us. No. But if you're craving broccoli, go eat some broccoli, right? Like if you're actually in tune with what you need, that's helpful. Physiology of taste. So to taste that chemical, remember it needs to be dissolved in saliva, diffuse into a taste pore, and contact gustatory hairs. Activation of taste receptors, so binding of food chemicals or tastant, depolarizes taste cell membranes. So we get a neurotransmitter release. So remember, when we talk about the nervous system, we're talking about chemistry and electricity. So the neurotransmitter is the chemistry of it. So it initiates a generator potential, that electricity, right, that elicits that action potential. Right? So the neurotransmitter, the chemistry eliciting a electrical component. So different thresholds for activation. Bitter receptors are the most sensitive because most of the time they could be super healthy, right? Bitter, like some of our greens are bitter and they're really healthy for us. Or bitter things can be more poisonous. So in nature, not a lot of things that are sweet are poisonous. So artificially, yeah, but not necessarily in nature. But some things in nature that are bitter happen to be poisonous. So all adapters, they're going to adapt in about 3 to 5 seconds, complete adaptation in about 1 to 5 minutes. It's that first couple tastes of food that really hooks us in. And then we just continue to eat to make sure that we're full or past full sometimes if that's what they're dealing with. So our gustatory pathway. So we want to think about cranial nerve 7 and 9 a lot here. So 7, 9, impulses from taste buds to that solitary nucleus of the medulla. Impulses then travel to the thalamus, and from there they branch into the gustatory cortex in the insula. And we saw a little bit of the insula in one of our labs. Hypothalamus and limbic system. So limbic system is the emotional component. I love this food. I hate this food, that kind of thing. And it's the appreciation of the taste. Vagus nerve transmits from the epiglottis, the little hang down area there that is showing in between the, it's more of the gatekeeper is what I call it. The epiglottis is the gatekeeper between, is this food or is this air? So it's between the esophagus and the trachea and the lower pharynx, so the lower throat area. I brought in this slide from the previous chapter, chapter 12, of the nucleus solitarius function for 7, 9, and 10. And I put a little star over there at the nucleus of the solitary tract. So you can kind of picture that from the last chapter and when we're talking about this. And remember that the lower brainstem regulation of visceral cardiovascular respiratory function, heart, lung, internal organ. So major coordinator of autonomic regulation of cardiovascular, respiratory, gustatory, GI, chemoreceptive aspects of homeostasis. I find this slide interesting because my dad had a heart attack. He's fine. He survived it. But he had the classic symptoms of his arms went numb and tingly. He got dizzy. Felt the weight on his chest. Honestly, of course, the dad of a chiropractor, he thought he just had a rib out and wanted me to adjust his rib. But long story short, he also had symptoms of a massive amount of saliva, and he just kept spitting and spitting and spitting a large amount of saliva, and I didn't quite understand what that symptom was all about until I was reminded of this going through my neurology diplomate program and studying the salivatory, the nuclei and the nucleus solitarius function here, 7, 9, and 10, and how this coordinates with the viscera and the cardiovasculature and the respiratory. And so now that makes more sense. So it's a little known, not often talked about symptom of a heart attack as well. So solitary nucleus is also notable for a large number of neurotransmitters, again, the chemistry behind the nervous system, and coordinates endocrine responses to internal bodily stresses. I would say a heart attack would be a pretty big bodily stressor there, right? Role of taste triggers reflexes involved in digestion, increases secretion of saliva into the mouth, increases secretion of gastric juice into the stomach, and may initiate protective reactions like gagging, reflexive vomiting, things like that. Innervation of our taste buds. This is a picture from page 333 in Nolte in your book here, and it's talking about different parts of the oral cavity and the connections into the brainstem. So what you can see there is the cerebellum's been cut away. So that white area, I'm going to grab my red pen here. So this white area here, remember, the cerebellar peduncles, the biggest one being in the middle, and then we have superior and inferior, and then that's that rhomboid fossa that they highlighted in red here. I'll highlight in blue. So that's the rhomboid fossa, and the fourth ventricle is there as well. And you can see that nucleus of solitary tract is right where they're pointing at. I like this picture. Seems to be a little bit clearer for the way that my mind works. So if it's helpful, great. So we have the tongue, right? 7 and 9 and some 10, biggest nerve in the back there. And going all the way up into that solitary nucleus in the medulla oblongata, passes through the pons, midbrain, up into the thalamus at that VPM, so ventral posterior medial, and we will get a whole chapter on just the nuclei of the thalamus. So it goes up through VPM and then out into the gustatory cortex and the insula, so deep in there. So when you see insula, remember it's insulated. It's a deep lobe of the brain that we don't often see when we study anatomy until we actually kind of dissect through a slice of the brain. So that's the gustatory pathway. Feel free to kind of stop and check this one out and then unpause and come on back for the next slide. This is saying the same thing, but this is a view from your book. So this is saying the same exact stuff, basically. It's just, it's a little, this picture's not as bright and easy to look at, I think. So that's why I found the other picture. But if you like this one, go for that. Influence of other sensations of taste. So again, taste is about 80% smell. And then we have thermoreceptors. So that cold smoothie over there on the left, and the mint would then be more kind of trigeminal, the chemical sense, common chemical sense. And then over on the right, the heat, right? So these things are going to taste differently if they're hot or they're cold. And then mechanoreceptors, feeling the movements and the mechanical chewing of things. What does it feel like? What's that texture feel like? And then nociceptors for pain in the mouth also influences taste. So some people will feel hot, spicy food as just pain and not pleasurable and not a taste. Temperature, texture, okay? So enhance or detract from taste. Olfactory epithelium, sense of smell. So in the roof of the nasal cavity covers superior nasal concha, contains olfactory sensory neurons. We saw those bipolar neurons with radiating olfactory cilia, the little hair-like projections. Supporting cells surround and cushion olfactory receptor cells. Olfactory stem cells lie at the base of the epithelium, and then we see bundles of non-myelinated axons of olfactory receptor cells. That's what's forming our olfactory nerve, or cranial nerve number 1. There's a picture of it there for you from, many chapters ago. I put that up there. I think it was in chapter 1 for the intro. So that bipolar neuronal type, rare, found in some special sensory organs, and here we are. Olfactory mucosa, it's also found in the eye and the ear. So these are unusual bipolar neurons. They're thin, apical dendrite, they terminate in a knob. and they're large, long, non-modal cilia. Okay, so olfactory cilia, so it doesn't mean that they're moving around. Like a modal cilia would be like a sperm cell, moves around. So these are non-modal. They radiate from the knob and then covered by mucus, so it's a solvent for odorants. It has to have some sort of carrier to our senses here. Olfactory stem cells differentiate to replace them. Now that same picture here, kind of bringing it into your mind's eye again so you can picture it. A little bit bigger of a view of that, looking up and to the left. Let's start looking at the olfactory tract and then how it's coming down on the left there. You could see the olfactory epithelium pointed out, and then the mucus layer, and then off to the right we're seeing the olfactory cilia, or that hair-like, but it's not a moving cilia, remember, and then the dendrite bringing the information in towards the cell body, and we see that olfactory sensory neuron, and then the olfactory stem cells separate over there, so just like the starter cell over there, and then you could see from the cell body going up the olfactory neuron all the way through that cribriform plate of the ethmoid bone. We see these little filaments coming up and through the lamina propria connective tissue. And then you can see all the way up, coming up into past that cribriform plate of the ethmoid bone, and then we're going to call it the olfactory bulb, that whole entire area there. We have these little glomeruli in there, and you'll see glomeruli again when we talk about the kidney, and it's the same kind of shape, but here it's nerve, and in the kidney that glomeruli is a blood vessel, and then where they're going to be making urine. And then we see this mitral cell, or the output cell. So again, feel free to pause at any of these and take some time and look at the different structures. Specificity of our olfactory receptors. Humans can distinguish about 10,000 odors and about 400 smell genes active only in our nose. So each encodes unique receptor proteins. So proteins respond to one or more odors. Each odor binds to several different receptors. Each receptor has one type of receptor protein, and we can sense pain and temperature in the nasal cavities as well. In contrast to our sense of smell, the dog's sense of smell, as you're probably familiar with, is much greater. So this article here that was published on pbs.org says, with an ability to smell between 10,000 and 100,000 times better than people, dogs can detect odors in parts per trillion. Check this out. That is the equivalent of a dog finding one dirty sock in a pile of 2 million clean ones. How can canines manage this mind-boggling feat? Their noses and their brains have evolved in tandem to make the magic happen. The article goes on to talk about how dogs have approximately 300 million receptors in their noses. In contrast, humans only have about 6 million. The section of a dog's brain that works in tandem with these receptors analyzes the scents dogs encounter. Their brains are 40 times greater than ours in this regard. The dog's ability to smell at such incredible rates comes from their physiology. So if that's of interest to you, I put the citation up at the top of where I got that from. It was from published on PBS. The olfactory pathway. Impulses from activated mitral cells travel via the olfactory tracts to the piriform lobe of the olfactory cortex. Now that's pretty specific right there. I'm not going to test you on the piriform lobe. However, I did put a picture of it over there for you. So if you look over to the picture on the right, I put a red arrow pointing at the piriform and periamygdaloid cortex there, that primary olfactory cortex, and it correlates to that pink area of the brain. But I'm not going to test you on that. That's just for visual aid purposes here. Some information to our frontal lobe is coming in to, you could see it all up in there. So olfactory bulb, olfactory tract, orbitofrontal olfactory area. Some information into the frontal lobe. Smell consciously interpreted and identified. What is it and what do we do about it? And then some information is going to go to hypothalamus, amygdala, and other regions of the limbic system. So this is going to put an emotional component to the odor and maybe put us into kind of a fight or flight or a calming relaxation. There's also an accessory olfactory system here. So this old kind of what they call vestigial or non-functional vomer nasal organ. You can see the word at the bottom there, and then I defined it up on the right in that paragraph. Again, not going to test you on this one, but if they're talking about something, we have to define it and at least mention it. So accessory olfactory bulb to the amygdala, to the hypothalamus, to hormones mediating aggression and reproduction. So kind of an interesting system here, and that paragraph just talks about how it's present in snakes and in lizards, and then it's present in some mammals, including cats, dogs, horses, cattle, pigs, and then it's also present in humans, but they think it's non-functional or has little function. So there's really nothing in us that's non-functional. It just means we don't know the function, or we kind of evolved past it a little bit. So this is the one that you want to memorize and really understand. So origin and course. Olfactory nerve fibers arise from the olfactory sensory neurons located in the olfactory epithelium of the nasal cavity and pass through that cribriform plate of the ethmoid bone. Make sure you know that, cribriform plate of the ethmoid bone, to synapse in the olfactory bulb. Fibers of the olfactory bulb neurons extend posteriorly as the olfactory tract, which runs beneath frontal lobe to enter the cerebral hemisphere and terminates in our primary olfactory cortex. Clinical testing, ask the subject to smell something and identify it. So I have that cranial nerve exercise video that I made for you. It's not really an exercise video, but cranial nerve exercises video that I made for you where you can, test your sense of smell. Homeostatic imbalance, fracture of this ethmoid bone or lesions of the olfactory fiber may result in partial or total loss of smell, a condition known as anosmia. And as you might be aware now, it's one of the first features of COVID-19 is the patients lose their sense of smell and their sense of taste. Another thing that happens with the sense of smell is the Alzheimer's peanut butter test. So for some reason, if you can't smell peanut butter, that's a sign of Alzheimer's. Not quite sure what that's about. It has its own Wikipedia page. I think I pointed that out before. Just kind of something interesting there. Homeostatic imbalances here. So the peanut butter test, anosmias, most result in from head injuries, neurological disorders, Parkinson's disease. If the person all of a sudden loses their sense of smell, you need to further investigate that and not let go of it until you find the cause. It's called uncinate fits. A little fun fact here, uncinate fits are olfactory hallucinations. So they smell something that isn't there, okay, prior to maybe an epileptic fit. Taste problems are less common. We would see that with different infections, head injuries, chemicals, medications, radiation for cancer of head and neck. One last anatomy slide here to kind of pull it all together. So what do you think is going on there with the Alzheimer's peanut butter test? If we look at that frontal lobe and the areas where there might be some sort of damage with Alzheimer's. So Alzheimer's defined is beta amyloid plaques and neurofibrillary tangles. We might see some tau proteins in there, all sorts of issues, and you could see where that affecting the frontal lobe there would actually affect the sense of smell as well. So a nice picture there to kind of pull it all together. So if you look at the front, this guy's got cerebrospinal fluid coming out of his nose. He fractured the cribriform plate of the ethmoid bone there. But you could see that olfactory bulb and then the nerve and tract going back. And then you could see where it goes to the lateral olfactory area. And then you can also see the amygdala there. So remember amygdala, I associate that with anxiety because they both have A's, but the opposite of anxiety as well. So like peacefulness as well. You can also see if you take the line up, instead of going over to the amygdala, you can see that where it is synapsing and coming up and over into that habecular nucleus. And then you could see how it's coming down, that green line there, and that habecular reticular fibers, and then we see it synapsing at superior and inferior salivatory nuclei. So the sense of smell is then going to make us drool if we were that dog looking at those steaks on the grill, right? And then remember, superior and inferior salivatory. Superior 7, inferior is 9. And then if you look a little further down, you can see the dorsal vagal motor nucleus, so cranial nerve 10 getting involved. And of course it would, because that's going to be that parasympathetic response getting us into rest and digest and ready for the internal viscera to start to digest food and open and close different sphincters. And you'll learn all of that in your digestion quarter. Looking to the right, I thought that was just a nice clear picture to be able to show you olfactory bulb tract, trigone, and then out to the lateral stria area. And then in the red, you could see that as well. Okay, so hearing and balance. So looking at the ear for not just hearing, but also the balance systems of the body. We have 3 major areas of the ear that we want to make sure that we know. It's the external ear. So that is really just for hearing only. It's like when you cup your ear or put your cell phone in a cup or a bowl in order to magnify the sound, right? 2, middle ear, the tympanic cavity, that's for hearing only as well. And we talk about the middle ear a lot in chiropractic and otitis media, which is infection or inflammation of the middle ear, and how an adjustment seems to help that a lot. I always have good luck with that. 3, internal ear, hearing and equilibrium. So receptors for hearing and balance respond to separate stimuli, so they're activated independently. So this is where we get into more of the neuro of things here. So let's look at the structures here. It's the name of the class, right? So the auricle or the pinna, if I were to ask you to touch your ear, that's probably what you would touch, right? So that's what you're going to kind of wiggle. And then there's the helix coming around, and then the lobule or your earlobe. That external acoustic meatus, that ear hole, basically, you'll see it called the EAM as well. Right? So just external acoustic meatus. And then if you look back at the upper area, so that's our external ear. And then the middle ear is coming up next here when we see that tympanic membrane, and we'll get into the specifics there a little bit bigger. And then the internal ear, or that labyrinth, and we're going to look at that and the innervation of that area as well, and talk a lot about the pharyngotympanic or auditory tube, and the fact that when we adjust babies, well, when we adjust anybody, but babies, that's more horizontal because they don't have a cervical curve yet. And so it's really important to adjust and get that baby on their belly for tummy time in order to start to get that cervical curve to develop. So that eustachian tube or pharyngotympanic auditory tube, I always call it eustachian tube because that's what I learned it as, but they rename things. So pharyngotympanic tube now. Is going to the nasopharynx from the tympanic area. So this tube is more horizontal in babies, and as we get a cervical curve, it starts to get a little bit more vertical and creates that little bit of tension and the mirror gravity in which things can't get infected as easily because it's not as stagnant. So if you have drainage, things don't get infected as easily. But if it's horizontal, it's not draining and it just sits there stagnant. So we think of it like a puddle outside, like a whole bunch of debris can get in there. And then if you were to just put some bleach in that puddle and then walk away for a couple of days, like it would get better, but then it would get worse again, right? So that's the idea of like antibiotics with these middle ear infections, and it's just stagnant in there. So the idea of encouraging a better cervical curve is a much better longer term approach. Yes, sometimes you might have to get the junk out of there and bleach the puddle, as I say it, but the idea of we change the structural alignment is the idea here. External ear, so what you want to do here is look at the picture on the left. Those are the things you want to memorize. The picture on the right, that's just a couple extra things, just a couple. I think that the left one is easier to memorize. I like things that are color-coded. So we see that superior crus. If you look at the top left, the way to do this is you draw it. Okay? So you draw the superior and inferior crus and the antihelix first, and I'll show you on the next slide. And then after that, draw the helix, or that outer ear area, all the way down to our lobule area there. And then you can draw the tragus and the antitragus. And then that concha is just the area that is in the middle that was kind of created by that tragus, antihelix, antitragus, inferior crus like boundaries there. You could do it in any order. You just draw it in any order like that, but I draw it first with the superior and inferior crus and then the antihelix. Okay, and then sometimes I draw the tragus next and the antitragus. So just have a starting point and an ending point, and then it'll make it make a little bit more sense. Auricle is a pinna. It's composed of a helix and a lobule, so the earlobe, funnels sound waves into the auditory canal. External acoustic meatus, that's the auditory canal, it's the ear hole. A short curved tube lined with skin bearing hairs, sebaceous glands. Sebaceous is oil, remember, and ceruminous is earwax, and it transmits sound waves to the eardrum. So drawing the ear here, see if you can do that. Make sure you can label this picture. I gave you some directions here on a way that you can draw that. So go ahead and pause, take 5 minutes, draw the ear, do it a couple of times, make sure that you can get it. The boundary between the external and the middle ear is the tympanic membrane. So sometimes the drum section is called the tympany section. So those are kind of synonymous. So connective tissue membrane that vibrates in response to sound. That's the tympanic membrane. It transfers sound energy to bones of the middle ear. Let's take a look at the middle ear, that tympanic cavity. So we can see a small air-filled mucosa-lined cavity in the temporal bone. It's flanked laterally by the eardrum, flanked medially by the bony wall containing the oval or vestibular and round or cochlear windows. And you can see the picture there. Let's take a little look here, shall we? I have my red marker here so you could see the tympanic membrane. Kind of looks like a contact lens, but that's the eardrum. So think more of the tympanic drum that was in the slide before. Here are those 3 bones. We're going to talk about those, the 3 tiniest bones of our body here with the auditory ossicles. Note the OS means bone, right? So auditory bones. The malleus, the incus, and the stapes. So malleus may be called hammer, incus might be called anvil, and the stapes looks like a stirrup, so it might be called that as well. And then if you look above there, you can see the entrance to the mastoid antrum and the epitympanic recess, and I have a slide coming up for that mastoid antrum, so we'll take a look at that, but note that hole there. And then you can see the oval window deep to that stapes, or that stirrup-looking bone. And then moving up and over to the right, you can see the semicircular canals. We're going to get way more specific with those in a minute. The vestibule. Then you can see vestibular cochlear nerve. So the vestibular part of the nerve being the upper area, and then the cochlear part of the nerve being the lower area. And you can see it kind of looks like a snail shell, that cochlea. So vestibular, again, being for balance, and cochlear being for hearing. And then you can also see that pharyngotympanic auditory tube that I talked about with babies, it being more horizontal, and the cervical curve helps it with becoming a little bit more vertical and allowing for more drainage. A little bit more on the ear ossicles. You can see a little bit clearer of a picture there. The malleus, the incus, and the stapes, 3 smallest bones of the body that we have. They're suspended by ligaments. So ligament, remember, is bone to bone. Tendon is muscle to bone. So ligaments and joined by synovial joints. They transmit vibratory motion of the eardrum to the oval window. Tensor tympani, look at that little muscle there. So I'll have my marker here, so this one right here. So looking up, that tiny little muscle, that tensor tympani, and then we have our stapedius muscles as well. And you can see this teeny tiny one here. It's even smaller. Look at how small that one is. So stapedius muscles contract reflexively in response to loud sounds to try and prevent damage to the hearing receptors. Middle ear, so that mastoid antrum I was talking about is in this slide here. So let's look at the top epitympanic recess, superior portion of the middle ear. It makes sense. Epi means above. Mastoid antrum, canal for communication with the mastoid air cells. I had a patient one time that had mastoiditis, so her mastoid air cells were filled with mucus, maybe. We weren't really quite sure. It was just a finding on the MRI. So if you look, the structures in this picture here have been removed from the middle ear, but if we have that pharyngotympanic tube, then the middle ear, and then the mastoid antrum is like this kind of entrance into the mastoid air cells. You could see where that would make sense that maybe there was an ear infection. And when you look it up, it'll say that maybe an ear infection that went untreated and then went into the mastoid air cells. So my patient just had migraines that no matter what I did, I couldn't get her migraines to alleviate. And that was really frustrating, and turned out she had mastoiditis. So a little antibiotic, as much as, we don't really want to do that as much, but a little antibiotic and then continued chiropractic care and lymphatic drainage really did the trick. Pharyngotympanic auditory tube, we looked at that. It helps to equalize pressure in the middle ear cavity with external air pressure. So think of that the next time that a baby is screaming on an airplane. They're trying to equalize this pressure here, and you could do just a little bit of work on the back of the neck to try and release that, so we can kind of move that cervical curve so you could release the pharyngotympanic tube a little bit. Nice picture here, really gives you a good idea of the structures here. We can see the round window at the bottom in this area here. The tympanic membrane, again, looks like a contact lens to me, but think eardrum instead. And then the ossicles there. So just a bigger picture of what you saw before. So kind of hang out with this picture, make sure you know what's going on here. So we could see this entrance to that antrum is what I wanted to point out by showing this slide again, really. So this little circular shape there. There's two major divisions we want to talk about with the internal ear. So the bony labyrinth and the membranous labyrinth. The bony labyrinth is in blue on that picture, and then the membranous labyrinth is in that orange kind of reddish color there. So the bony labyrinth is tortuous channels in the temporal bone. So tortuous, think of like an old country winding road. That's what we think of when we think of tortuous. So we have three regions: the vestibule, the semicircular canals, and the cochlea. And it's filled with perilymph, which is similar to cerebrospinal fluid or lymphatic fluid. And then we have the membranous labyrinth. It's a series of membranous sacs and ducts, and it's filled with potassium-rich endolymph. So when I look at that structure over there, and I look at those semicircular canals, I think of like a gyroscope, which is really going to help you try and figure out where you are in space. Looking here, I want to point out number 1 and 2, the saccule and the utricle there. So let's look at the saccule. I'm going to circle the words here in red. So saccule area here, and then the utricle, I'll use green. The utricle area right here. So saccule is going to be continuous with the cochlear duct. Utricle is going to be continuous with the semicircular canals. So these sacs here are going to house equilibrium receptor regions and respond to gravity and changes in the position of the head. So these become, this whole apparatus here is really important to us as chiropractors, and in doing neurological rehab. A lot of times our patients will come in and have some sort of vertigo or dizziness or some sort of balance issue, and we can really impact their life here for the better by understanding this and knowing how to treat it. So let's take a little bit of a look here. So our semicircular canals, so the membranous labyrinth here is semicircular ducts. The bony labyrinth is the semicircular canals. The function being equilibrium, rotation, or angular acceleration. And the receptor region is the crista ampullaris. The vestibule is the bony labyrinth, and the utricle and the saccule is the membranous labyrinth. And then their function here is equilibrium and head position relative to gravity and linear acceleration. Utricle is more thought with just horizontal, or like driving in a car movement, and saccule is going to be more up and down, so like an elevator kind of movement, or just jumping up real quick from a seated or laying down position as well. So equilibrium, head position relative to gravity and linear acceleration, and the receptor region is the macula. And then for the bony labyrinth of the cochlea, we have the cochlear duct, also known as the scala media. Its function is hearing. Its receptor region is the spiral organ. Okay, so the cochlea and the spiral organ go together. So 3 canals oriented in 3 planes of space is what we want to remember about our semicircular canals. We have our anterior, lateral, and posterior. So anterior and posterior are at right angles to each other, whereas the lateral canal is horizontal, and you can see it kind of in that picture over there. It's a little confusing to look at, but you can kind of pick it out. So look at that lateral one, how it's kind of like flat, and then you can see the anterior and posterior at right angles to each other. The membranous semicircular ducts line each canal and communicate with the utricle. Remember our saccule and our utricle for our linear acceleration and deceleration. Ampulla is an enlarged area of ducts of each canal that house equilibrium receptor regions called the crista ampullaris, and we'll get into that. Receptors respond here to angular or rotational movements of the head. So think about rotation, think about a figure skater that's spinning around. That's really going to stress this system here. How do they deal with that kind of stuff, right? So let's talk about that. Another picture here, just that same picture. So each time that I show this picture, hopefully it's less and less intimidating, and we might be able to pick out a couple of things. So let's look here. We've got our saccule. Okay, so we're here for the saccule right there, and then the utricle is up here, and then that crista ampullaris and the membranous ampullae is the new one. So it's that purple, looks kind of like a dumbbell weight kind of thing, right? So you can see another one right there. Yep. And then that lateral, posterior, anterior, semicircular ducts in the canals here. So just duct work in the canal, right? So that lateral, it's kind of laying flat here is what I was trying to explain there. And then the other two are at right angles to each other, remember. Looking over to the right, we can see facial nerve. What number is that? 7. Good. And then we have our vestibular part of our vestibular cochlear nerve. Okay, so coming from this area here, and then cochlear for hearing. Okay. And then we could see the macula, this little purple area here. And then the spiral organ kind of spiraling through that cochlea. And then you can see the cochlear ducts in the cochlea, so just duct work again, basically, in that area. And then you can see round window here. You can see this, whoa, you can see the stapes here. Okay, starting to piece it together a little bit more. And look at, this is all temporal bone here. Okay, temporal bone. So otoconia, these are small crystals of calcium carbonate in the saccule and the utricle, so linear detection, remember, of the ear, that under the influence of acceleration in a straight line cause stimulation of the hair cells to by their movement relative to the gelatinous supporting substrate containing the embedded cilia of the hair cells. So what does that mean? I think of this level that I put down here. So the level has water and an air bubble in it, and it tells you where straight is. And it's what I picture when talking about this system here, but the otoconia would be similar to what that air bubble is in the analogy here. And then the gelatinous supporting substrate would be the water in the level here. So as we move around, those otoconia are going to give us this idea of where we are in space. If you've ever had like the hula hoop with the sand in there, it's a very similar kind of concept, and it kind of moves around and gives it a little bit more weight in that hula hoop. So it gives us a little bit more of an understanding of where we are in space here. Here we can see the receptors in the utricle and the saccule detecting linear acceleration and position of the head. So look here, my little red marker, at these otoconia or otoliths, the calcium carbonate crystals at that saccule and the utricle there. Cochlea, spiral conical bony chamber, size of a split pea. It extends from the vestibule, coils around the bony pillar, and then contains the cochlear duct, which houses the spiral organ or the organ of Corti, and ends at that cochlear apex. It is divided into 3 chambers: the scala vestibuli, which is abutting the oval window containing our perilymph, remember. The scala media contains our endolymph. Scala tympani terminates at the round window and contains perilymph. So scala vestibuli and tympani both contain the perilymph, and media is endolymph. Scala tympani and vestibuli are continuous with each other at the helicotrema or the apex. The roof of the cochlear duct is the vestibular membrane. The external wall is the stria vascularis, which secretes endolymph. The floor of the cochlear duct is composed of the bony spiral lamina, the basilar membrane, which supports the spiral organ. The cochlear branch of cranial nerve 8 runs from the spiral organ to the brain. Here's a picture kind of showing a little bit larger of what we saw in a slide previous, so we could see look over to the right here, that spiral ganglion. So ganglia, remember, is just a cluster of cell bodies outside of the central nervous system. If it was inside the central nervous system, what would we call it? Nucleus. Yes, good job. So coming in here, let's look around. So you can see that scala tympani here containing the perilymph, scala vestibuli up here containing perilymph, and then in the middle here that contains the endolymph, this one here, that's the cochlear duct of the scala media, media being middle, so vestibuli, medii, and then tympani. And then just this area here is that stria vascularis. Here's the spiral organ area. And then basilar membrane, anytime you see that, I always think like basement. Basilar membrane, basement, it's what's like the basement of this area here. And what else do we see? We see, if you come up top, you can see the tectoral membrane here, and then the vestibular membrane here. Okay, so the 3 things to note: scala vestibuli, scala media, and the scala tympani. Now this is just the same picture, but just enlarged right here at, you can see that tectorial membrane up top, you can see the supporting cells, the outer hair cells, that basement or basilar membrane, and you can see the fibers of the cochlear nerve coming through here. Okay. Fine fibers there of those afferent nerve fibers. This is a neat picture here of those outer hair cells, inner hair cells, just a scanning electron microscope view for you. So you might have heard of cochlea before, like a cochlear implant. So this child here has a cochlear implant. This piece here, this white piece up here, he had surgery, and this is magnetized, and he can take this piece off, and it pulls off just like a magnet would. I had a patient that had this. He would come in and pull the cochlear implant, that magnetized part, off of his head, hand it to me. I'd set it on the table, I'd adjust him, and then I'd hand him his implant back. He'd put the hearing aid looking apparatus on the ear there, and then flip it back, and it was magnetized, so he didn't actually have to place it back. He would just flip it back, and it would catch the magnet and pop right back onto his head. So that's an apparatus to help him hear. So how do those cochlear implants work, right? So if you look at the numbers here, 1, sounds are picked up by a microphone that's mounted in the external earpiece. 2, the speech processor digitizes the sound into signals that sends the signals to the transmitting coil. Number 3, that transmitting coil sends the coded signals as radio waves to the cochlear implant underneath the skin. So remember, it's magnetized and holding together. 4, the internal processor is placed in the mastoid bone behind the ear. The cochlear implant delivers electrical energy to an array of electrodes which has been inserted into the cochlea. 5, the electrodes along the array stimulate the remaining auditory fibers in the cochlea. 6, the resulting electrical sound information is sent through the auditory system to the brain. This is just mind-blowing to me. I mean, this has been around for a while, but it's just mind-blowing. What does this actually sound like? How would we even know what it sounds like? How are they able to actually transmit that into a nerve impulse? That's absolutely amazing stuff to me. So the macula. So macula are sensory receptor organs that monitor static equilibrium. One organ is located in each saccule wall and one in each utricle wall. They monitor the position of your head in space, and they play a key role in controlling posture. So this is important to note as we are adjusting patients and they're coming back in with the same listings, or they have scoliosis, and why? What's going on here? So I think about the cerebellum and the idea that, hey, there's this balance system where maybe the cerebellum isn't understanding exactly where we are in space and able to compensate. But there's also going to be this aspect as well in the inner ear, this macula specifically, and a couple of the other structures that we're talking about. They're going to control posture. So why do we have a crooked posture? Why do we have scoliosis? Why do we have forward head posture and not know it and are unable to correct it? And so instead of just adjusting over and over and over again and wondering, why isn't this working? I thought chiropractic works. It does. It totally works. We need to align the structure, but we also have to understand the function of the nervous system and reset that. So there might be an issue. A lot of times there is an issue, some sort of inner ear, very subtle, or it could be pretty extreme as well. And we do just a little bit of work on the inner ear structures, and we can get some pretty good results. So that's what we're doing here, right? So this is responding, the macula responds to linear acceleration forces, but not rotation. Anatomy of the macula. So each is a flat epithelium patch containing hair cells with supporting cells. Hair cells have stereocilia and true stereocilium called kinocilium. So these are located next to the tallest of our stereocilia. I got pictures coming. Stereocilia are embedded in otolith membrane. So when you hear lith, think stone. When you hear oat, think ears, right? So this otolith membrane, we have a jelly-like mass studded with otoliths, or that calcium carbonate stones. So otoliths increase membrane's weight and increase its inertia or resistance to changes in motion, kind of like I was talking about that sand in the hula hoop, making it a little bit more manageable. The utricle macula are horizontal with vertical hairs. They respond to change along the horizontal plane, such as tilting the head. Forward backward movements stimulate the utricle. The sacral macula are vertical with horizontal hairs, and they respond to changes along the vertical plane. So think of an elevator. Okay. So the hair cells synapse with the fibers of the vestibular nerve, whose cell bodies are located in the superior and inferior vestibular ganglia. So this is part of the vestibular cochlear cranial nerve. And then we'll see this kind of morph into how is this getting up and into the brain and communicating. So activating receptors of our macula. Hair cells release neurotransmitters continuously. So acceleration and deceleration causes a change in the amount of the neurotransmitter released, which is going to lead to a change in the action potential frequency to the brain. So the density of the otolith, those little stones, okay, so otolith membrane, causes it to lag behind movement of hair cells when the head changes positions. So the base of the stereocilia moves at the same rate as the head, but the tips embedded in the otolith are pulled by lagging membrane, causing the hairs to bend. So our ion channels open and we get depolarization. Bending of hairs in direction of kinocilia depolarizes the hair cells, increases the amount of neurotransmitter release, more impulses travel up the vestibular nerve to the brain. So bending of hairs away from kinocilia hyperpolarizes receptors. We get less neurotransmitter released and reduces the rate of impulse generation. So the brain is then informed of the changing position of the head. Here's a neat little picture. Hopefully it helps clear it up. So we see the top picture, the head is upright and just regular old gravity telling us where we are in space here, the steady stream of action potentials on that vestibular nerve. We know what's going on. And then we tilt our head forward. The hairs bend towards the kinocilium. The hair cells depolarize and the nerve fiber is excited and the action potentials in the vestibular nerve are increased. And then the head tilts backwards, the hairs bend away from the kinocilium, the hair cells hyperpolarize, nerve fibers are inhibited, and we see a decrease in action potentials in the vestibular nerve. This is how we know if we are going forward or backwards, or flexion and extension. So if we get dizzy in extension, think about this when you're doing your ranges of motion. The crista ampullaris. So the receptor for rotational acceleration is what's called the crista ampullaris, or we could just call it the crista. So it's a small elevation in the ampulla of each semicircular canal. The crista are excited by acceleration and deceleration of the head. So the major stimuli are rotational or angular movements such as twirling of the body. Semicircular canals are located in all three planes of space, so the crista can pick up on all rotational movements of the head. the anatomy of the crista ampullaris here. So each crista has supporting cells and hair cells that extend into gel-like mass called ampullary cupula. So the cupula here. Dendrites of our vestibular nerve fibers encircle the base of these hairs. Activating receptors of the crista ampullaris. So the crista responds to changes in velocity of rotational movements of the head. Inertia in the ampullary cupula causes the endolymph in the semicircular ducts to move in direction opposite of the body's rotation, causing the hair cells to bend. Here's our picture of, if you look at the ampulla cupula on the right-hand side there, right in this area here, nice picture of that. We can see the hair bundle, the kinocilium plus the stereocilia. We can see the hair cells and the supporting cells, and this whole area right here being the crista ampullaris right here. And then you could see the fibers of the vestibular nerve if I erase my, there you go. Nice picture of that, I think, the scanning electron micrograph. Kind of cool looking. Activating receptors. So bending hairs in the crista causes depolarization. We see a rapid impulse reach the brain at a faster rate. Bending of the hairs in the opposite direction causes the hyperpolarization. So fewer impulses reaching the brain, and that the brain is informed of our head rotations. So axis of hair cells and complementary semicircular ducts are opposite. So we see a depolarization occur in one ear, while hyperpolarization occurs in the other ear. Endolymph will come to rest after a while, so the system detects only changes in movement. And check out our figure skater here. So she's standing there in the first picture at rest. The cupula is standing upright. We can see the fibers of the vestibular nerve at the bottom there. And then the section of the ampulla is filled with endolymph. So picture that level, remember. It's kind of a good analogy for this. And then when she is spinning, right, so she's spinning during rotational acceleration, endolymph moves inside the semicircular canals in the direction opposite of the rotation. It lags behind due to inertia. Endolymph flow bends the cupula and excites the hair cells. As rotation movement slows, endolymph keeps moving in the direction of rotation. Endolymph flow bends the cupula in the opposite direction from the acceleration and inhibits the hair cells. Normally, when we talk about nystagmus, we're usually talking about it as a pathological sign or symptom here, where we have the patient follow our finger in that normal H pattern, and sometimes we see the eyes give this kind of wiggle waggle and not be able to kind of keep up appropriately with tracking our finger. But sometimes nystagmus is just the normal occurrence. So for example, vestibular nystagmus. So the semicircular canal impulses are linked to reflex movements of the eye. So nystagmus, this book is defining it as strange eye movements during and immediately after rotation, often accompanied by vertigo or this kind of dizzy feeling. As rotation begins, the eyes drift in the direction opposite to rotation. Then the central nervous system compensates, causing a rapid jump towards the direction of rotation of the eyes. As rotation ends, the eyes continue in the direction of spin. Then they jerk rapidly in the opposite direction. So it's this quick little eye jerk happening because you're spinning way too quick. That figure skater spinning way too quick for the eyes to keep up. So that's a vestibular nystagmus. Equilibrium information goes to reflex centers in our brainstem. It allows for fast reflexive responses to imbalance so we don't fall down. Impulses from activated vestibular receptors travel to either the vestibular nuclei in the brainstem or to the cerebellum. We have three modes of input for balance and orientation. We look at vestibular receptors, visual receptors, and somatic receptors. So this input Information about the body's position in space, or proprioception, comes from three main sources and is fed into two major processing areas in the central nervous system. So let's look here. We have at our top row the three aspects: the vestibular receptors, the visual receptors, and the somatoreceptors: skin, muscle, joints. Why do we stretch and kind of figure out where we are in space, right? So let's follow the vestibular receptors down first, right? So we can see here in our arrows the vestibular receptor going to the cerebellum here, and also vestibular nuclei, and then the vestibular and cerebellum here chit-chat with each other. So the brainstem and the cerebellum kind of check in on each other, and then from here we have oculomotor control, and we also have spinal motor control. So neck, limb, trunk movements. So postural alignments and imbalances and movements and compensations depending on our perception of balance. This is why this is so important as a chiropractor, and we have to be checking to make sure that their semicircular canals are appropriate. So it's such a basic function of why they might be out of alignment. Let's look here. The visual receptors, pretty much the same thing. So visual receptors coming into cerebellum and vestibular nuclei, and then so does the somatoreceptors going both into cerebellum and vestibular nuclei. I'll erase some of these so it doesn't look so busy. There we go. So then I want to make sure that you see the ocular motor control, the eye movements. So why do we do eye movements all the time for neuro rehab? It's everywhere. It's all throughout the books. It's all throughout all of this information. It always comes back to eye movements, cross-crawl activities, right-left connection of the brain, and the cerebellum and the vestibular nuclei here. So cranial nerves 3, 4, and 6. So remember our SO4, LR6, all others 3. 3 is going to be pupils as well. So we'll take a look at that. So the output here, responses by the central nervous system provide fast reflexive control of the muscles serving the eyes, neck, limbs, and trunk. So equilibrium problems are usually unpleasant, can cause nausea, dizziness, loss of balance, and we'll see nystagmus in the absence of rotational stimuli present as well. That's why we're checking their eye movements. Follow my finger, do the H pattern. Do they have this nystagmus show up because of the vestibular nystagmus response when it is inappropriate here, when it's a pathological, can't keep up kind of concept. So the vestibular nuclei project primarily to the cord, okay, cerebellum, and nuclei of those cranial nerves 3, 4, and 6. So it's coordinating our posture, head, and eye movements. So here are our eye movements chart here. So SO4, superior oblique, depresses the eye, turns it laterally. LR6, lateral rectus, abducens nerve, moves the eye laterally. All others are 3, are the ocular motor. Okay, so these are the extrinsic eye muscles. So remember 3 is also going to be for a pupillary, which is not considered extrinsic. So a little more info on your eye muscles here. So there's 6 strap-like extrinsic eye muscles originate from the bony orbit and then insert on the eyeball, enable the eye to follow moving objects, maintain the shape of the eyeball, and hold it in the orbit. So we have 4 rectus muscles. Rectus just means straight here. Rectus muscles originate from the common tendinous ring, and their names indicate their movement. So superior, inferior, lateral, and medial rectus. 2 oblique muscles move the eye in a vertical plane and rotate the eyeball. These get a little tricky. So superior and inferior oblique muscles. Make sure you check out that eye simulator chart or link actually at the website if you want more information on what muscles are doing what. It's kind of interesting and it's not just 100% of this muscle doing that. It's 50% doing this, 50% of this muscle is moving. So it's kind of neat. So check it out if that's of interest to you. Nice picture of the eye muscles here. So looking at the top there, you can see that superior oblique tendon and then the superior oblique muscle. Looking over at the superior rectus muscle, that straight one, and then lateral rectus, the straight one going back, so LR6. Inferior oblique muscle, inferior rectus muscle. Another viewpoint here, so you could see the axis of the rotation of the eye, and you could see that trochlea and that weird kind of superior oblique tendon, and why that would be a tricky one to fully understand and be able to explain in easy terms. Another nice viewpoint here, you can see that trochlea, the superior oblique up top, you can see inferior oblique on the bottom, and then the 4 recti muscles. Feel free to pause at any of these and make sure that you get these down, because this shows up in other classes as well, and you'll need to know these muscles for my class, and you'll need to know these muscles for other classes as well. So just a little switch of gears here to check in on the track. So we want to, if we're talking about the vestibular system here, we also want to consider the tracts here. So the medial vestibulospinal tract, the lateral vestibulospinal tract. So remember these, they're the anti-gravity muscles, posture, balance, tilt, compensation. So coming from the vestibular aspect of the brain, vestibular nuclei, and then going to the spine, and then affecting the motor pathways that way. So just want to keep that in the back of your mind's eye as we go further into the chapters, that there's more to this story here. So this I want to point out again. Why do patients have scoliosis? Why do they have some listings that show up over and over and over again, which listings really could be considered like super minor scoliosis if you really wanted to get like philosophical on that. So vestibular fibers influence anti-gravity and neck muscles. The idea of what do those tracts have to do with it, right? So it arises in the lateral vestibular nucleus, travels through the ventral part of the lateral funiculus near spinal thalamic. So spinal thalamic coming up, vestibulospinal coming down. And sends excitatory projections to the motor neurons for our anti-gravity muscles and ipsilateral or same side spinal levels. The vestibular system brings about postural changes to compensate for tilts and movements of the body. So as a chiropractor, it begs the question of, well, why didn't it straighten it out after it did that, right? So some examples here of some of our postural muscles are levator scap, upper trap, scalenes, erector spinae, hamstrings, iliopsoas, rectus femoris, piriformis adductors, and then always bringing it back to this Janda's upper cross, lower cross syndrome here. And why are we in that forward head posture? Why does our body not know how to straighten itself out and disinhibit the facilitated muscles and activate the inhibited muscles? So just things to keep in the back of your mind's eye as you're starting to build this picture on how do we help people with this information. So these muscles are postural muscles made up of about 51% or more. So the majority is going to be our slow twitch muscle fibers. So those postural muscles are tonic in makeup, which means they're designed to contract at lower loads for longer periods of time. So we're standing for longer periods of time. It's not that quick explosive muscle in order to sprint, right? So they have a greater capacity for sustained work, but are prone to shorten due to overuse, underuse, force, and trauma. Postural muscles can become hyperactive, tight, and painful at times. Just check out your upper traps most of the time. Those are going to be a good example of that. If the postural muscles are tight, so is the surrounding fascia, that connective tissue, and this affects the way that we're going to carry ourselves, flexibility, mobility, balance, alignment, and posture. And the treatment for this being adjustments and neuro rehab, basically. So another view here of the medial and lateral vestibular spinal tract and the vestibular nuclei. So you could see them down at the bottom there. So go ahead and pause this slide and kind of check that out. Make sure you're looking for the vestibular nuclei in green, that lateral vestibular tract, and then checking out that medial vestibulospinal tract, or the descending MLF, or medial longitudinal fasciculus. So when we think about the one above it, right? So the ascending MLF, I'll circle that one in purple here. So this medial longitudinal fasciculus here. We've seen this before. We usually see it when we're talking about yoked eye movement and how do we get the eyes to move at the same time. And so we'll check that out in later slides. So our medial vestibular tract arises from the medial vestibular nucleus and reaches both sides of the cervical spinal cord by projecting caudally or towards the tail through the MLF. So this would be why a nice cervical adjustment might reset some of this. So it stabilizes head position as we walk around or when our heads move in space in other ways, and coordinates head movements with our eye movements. There's a nice little picture here, exaggerated activity in our lateral vestibulospinal tract. Here's the MLF, or the medial longitudinal fasciculus, right in the middle there in the purple. So let's go by the numbers here. So we're talking about the horizontal gaze center here. So how do we have this yoked vision? How does my right eye look to the right and my left eye look to the right at the same time? It's not controlled by the same nerve, so there needs to be some sort of connection here. So this MLF is that connection. So let's look here at number 1. The horizontal gaze center gives input to the abducens nucleus to direct gaze to the ipsilateral side, same side. Number 2, one subset of the neurons projects directly to the same lateral rectus. Number 3, another subset of neurons in the abducens nucleus crosses the midline and travels in the MLF, or the medial longitudinal fasciculus, to the contralateral ocular motor nucleus. So let's pause there. In purple here, we could see that. So this guy right here, this dotted line is just the midline. That's not actually a structure. So this MLF is connecting the ocular motor nucleus and that abducens nucleus. So this is white matter connecting the two. So remember, when we see white matter, we think, okay, maybe our multiple sclerosis patients might have something affected here. So number 4, the ocular motor neurons innervate the ipsilateral medial rectus and the eye moves to the contralateral side. Number 5, both eyes move in the same direction. So a lot going on here. That's why we check eye movements. So it seems so simple. Follow my finger. It seems such a simple thing, but we're learning more and more that if they can do that, they're probably pretty well neurologically intact. And if they can't, we can trace it to a certain area depending on what movement is having trouble. So our smooth pursuits are used when tracking a slow-moving object, so follow my finger with your eyes, and the aim is to keep that object on the fovea, the sharpest vision of both eyes, and we can now see that MLF, this is just a flipped side, so don't let that trip you up. So we still see the exact same thing, and then the only thing it's adding in here is this connection into the vestibular nuclei here, and then connection into cerebellum, pontine nuclei, and then going to visual association cortex and the frontal eye fields, or Brodmann's 8, we'll call that eventually. So let's look at the VOR, the vestibular ocular reflex, now that we've had, that we're coming to the end of this PowerPoint. So we could see what we just saw, right? So we see cranial nerve 6, we could see cranial nerve 3, and the nucleus here, and the MLF crossing the midline, going to the vestibular nuclei, and then the vestibular ganglion, and this is now The new part here is the horizontal canal from above. So when we rotate our head and keep our eyes fixed now, so instead of follow my finger, it is hold your gaze at my finger and turn your head into rotation left and right. And we're going to see what that looks like. That's the vestibular ocular reflex. So that's like the side door of getting into these nerves, into these pathways, and into the cranial or the extra ocular eye movements. So if they have trouble with one of these movements while they're following your finger, you can simulate the same movement but keeping their eyes still per se, but having their head rotate in order to facilitate that. So what's it say here? VOR, rapidly adjust the eye movements to head movements so that the gaze can remain fixed on an object even though the head is moving. So it keeps an image stable on the retina despite movement. So just looking at the definition here, nystagmus again, because we talked about that a little bit. Rapid rhythmic back and forth eye movements consists of a rapid component or a quick flick of the eyes in one direction and a slow component or a slow drift in the opposite direction. So we name it by the rapid component. So if it's a quick flick to the right, it's a right nystagmus. Rotation of the head activates the vestibular apparatus and activates the VOR, the vestibular ocular reflex. When head rotation is greater than what can be compensated by the VOR, the eyes reset with that rapid movement in the same direction as rotation. So that's that vestibular nystagmus we were talking about. And then compensatory movement of the VOR can happen. This rapid reset is that VOR, or I'm sorry, vestibular nystagmus. So this is our last slide here. So you made it through, good job. So this is TNRR, or tonic neck writing reflex in chiropractic. So the idea also that we want to keep our eyes level with the horizon. So we have all of these other things going on. We want to yoke our eye movements together. We have the vestibular ocular reflex. We have the ability to keep our eyes fixed while our head moves, or keep our head from moving and then just move our eyes. And then we want to tie it back to what's going on with keeping the eyes level with the horizon at the same time. And what does that mean to us as chiropractors? So looking here, that vestibular division of cranial nerve 8 forms the afferent limb of the VOR, vestibular ocular reflex. Each semicircular canal has connections via the vestibular nuclei that are appropriate to cause eye deviation in its own plane. And then the idea that we want to keep our eyes level with the horizon in response to our subluxations or our fight or flight patterns, that hip going up, our shoulder going up. So that kind of running or fight posture as well can play a role in here. And what does that do to the muscles at the back of the neck and the muscles throughout the spine? But when you're palpating the suboccipital muscles, as pictured over there, they're really just a series of pulleys that you can see, that one will be tight on one side and be kind of crooked feeling and hypertonic on one side and not the other, because they're trying to keep their eyes level at the horizon. And all of the things that we just talked about here. So if we just go in there and reset that C2 body left, the body might see that as trauma, and it worked really hard to put that compensation in there so they won't get dizzy, so they will feel stable. So in my philosophy, we'll work from the bottom up, reset the sacrum, and move all the way up. And then this goes a whole lot easier in adjusting these upper cervicals to reset this. And then we do a neurological set and hold with eye movements to say, hey, it's okay. We've changed the structural alignment, and now we're going to change the functional reasoning behind why those structures were misaligned or subluxated in the first place. So you made it through. That was chapter 13 and 14 put together, and some of the chapter 21 and some of the visual aspects of that as well. So congratulations. It was another hefty chapter. I mean, it's advanced neuroanatomy. It's not a lot of easy stuff coming at you. So keep communication lines open. Check your Brightspace quizzes. It's designed to boil it down into 10 questions each time, and letting you know, hey, what are your boards looking for out of the information from this? So keep up the great work. I'm here for you. Reach out if you need me. All right, see you next chapter.